So good evening, all of you. So it's very nice to meet all the colleagues and seniors from Rajiv Gandhi whenever we have such CMEs. And today, whenever we discuss about cancer, particularly as we are reaching about to have World Cancer Day in 2 days, and whenever we discuss about cancer, two cancers definitely stand out, and we are discussing about those two cancers today: breast cancer and lung cancer. One of the cancers like breast cancer, they are detected in relatively in younger in early stages because of the superficiality of the disease of the superficial tissue, whereas in lung cancer majority of the patients they are diagnosed in metastatic stage. So today we are dealing with those lesser number of patients who are diagnosed in early stage lung cancer, at least pertaining to India. So let us take the opinions and thoughts of our young oncologists as well as the senior oncologists who are present with us today in this meeting. So for this panel discussion, we have our young colleagues, Dr. Satyanarayan, Dr. Arpit Jain, Dr. Pallavi. Are you there?
Yes, sir.
Yes,
Good
sir.
evening,
Good
sir.
evening, sir.
Good evening.
Yes, sir.
And we have senior oncologists with us, Dr. Pankaj, Dr. Rajat, Dr. Praveen, and Dr. Priyanshu and Dr. Kshitij. So I think
I am intermediate oncologist, sir.
So,
I'm not senior.
depending upon
I'm
situation.
an oncologist only.
nice to see you all.
Is he not in the young oncologist?
Young, but while in the category of hierarchy, I would say I am intermediate.
अरे ऐसा कुछ नहीं, उसमें यंग फीमेल्स होंगी या ओल्ड फीमेल्स होंगी, उस पे वो इंटरमीडिएट रहता है.
Yeah,
सर
but
है
our case
एक
is
स्पेशल
about
ग्रुप है सर,
relatively-
हम जैसों के लिए एक इंटरमीडिएट है सर.
ठीक है.
Yeah.
अबे तुम कम टू द पॉइंट. हाँ वेंकट,
Yes,
कंटिन्यू.
sir. So our case is about a elderly gentleman who is a retired colonel who is in surprisingly he is a non-smoker, presented with a mild cough. So in the army base hospital, chest X-ray was done, which showed a small lesion. And in view of the suspicion, even though he is not smoking, he is referred to the higher center where CT chest was done. But as he is retired, instead of going to the to proper channel, he went to a private hospital where Dr. Priyanshu is practicing, and PET CT was done. So within PET CT, a small lesion is seen in the left apical lobe. So now I want to ask Satyanarayan, Dr. Satyanarayan,
Yes, sir.
if you can see the small lesion in the apical lobe, left apical lobe here. So whenever a patient comes with a X-ray or CT scan showing a small lesion, let's say it is 3 to 2 centimeters. So what are the features in CT scan based on which you suspect and think in terms of cancer? Because you know majority of the SOLs, they need not be cancers, particularly non-smokers. So what are your thoughts on when you see such lesion in OPD? What are the features that will make you to suggest further investigation pertaining to cancer?
Sir, first I will see that whether the lesion is peripherally located or central located.
Okay.
So along with that, the size is 3 into 2 centimeter. It is round in shape, and sir, only single.
Yeah, single lesion.
So
Your point well taken. Whenever there is a suspicion, a significant size is the factor which you are mentioning. Dr. Arpit and Dr. Pallavi, would you like to add any more points to what already Dr. Satyanarayan has alluded to regarding the characteristics of lesion, which you suspect the cancer when you see a CT scan of the patient? Dr. Arpit?
Yes, sir. Sir,
Yeah.
we can discriminate it with the benign lesions, like if it is not having the fatty attenuation and the calcification. So these are the peculiar finding of a benign lesion. And then the we can follow the previous scan also. If the doubling time is matching with the if it is progressed by more than 2 millimeter in last 2 years, then it is there in the high likelihood of the malignancy category.
Yeah, so that is really important point. Whenever patient is having a serial scans, And when you see a growing lesion on with a significant proportion per year, as you said, so definitely that is one of the indicator of malignancy. Uh, Dr. Pallavi, do you want to add any more features on which you suspect malignancy when you see a single lesion in CT scan?
Sir, if it is encasing the vessels or it is infiltrating the mediastinum, more likely to be a malignant.
Yeah, but here it is very much independent of the mediastinum. It is in the
Yes.
lung parenchyma. So your points well taken. The invasiveness whenever it is there. So putting together all the points told by you three guys. So any lesion which is of significant size, particularly when it is greater than 1.5 centimeters, and in a CT scan when you see the speculated margin, and a lesion that is growing in size. So all these, and whenever you see a ground glass lesion with a solid component in it, so all these factors they point out towards towards malignancy, which will force us to evaluate in the lines of malignancy, particularly when they present to us.
Dr.
So,
Pradeep, I think any lesion which is more than 1 centimeter in size and having significant solid component, not cystic component.
yeah.
Your voice is
it needs
echoing.
to be
Manish,
evaluated.
voice is echoing.
Very
Yeah,
important that those patients, those scans which are showing a mass of more than 1 centimeter, they definitely warrant some sort of evaluation, either in form of biopsy, or if a mass is unequivocally appearing to be malignant on imaging, then probably these are those patients who can directly proceed with the surgery, and at the same time mediastinal evaluation can be done in these patients.
Yes, sir. So that's really important point what we have heard just from Dr. Pevin. It's so these are the conditions where we can directly proceed with the surgery and we can do the intraoperative evaluation of the mediastinal nodes for the exact staging. Point well taken, sir. So for this patient, because PET CT were done and it was decided to do the biopsy. So biopsy was done, and PET CT is showing only the single lesion in the left apical lobe with a very few subcentimeter prevascular lymph nodes, which are looking like a non-specific nature in terms of FDG, FDT. There are no other lesions anywhere in the body. And the biopsy was done, CT-guided biopsy and adenocarcinoma lung. Now, because CT-guided lung biopsy is something which is challenging, particularly in the places where I am practicing in the peripheral settings. And it is a routine procedure in apical institute like Rajiv Gandhi or AIIMS or in other institutions, academic institutions. So now I want to ask Dr. Pankaj sir, so what is the incidence of pneumothorax when you ask a patient to undergo a CT-guided lung biopsy? So out of, let's say, 20 or 100 cases, what is the percentage you see the incidence of pneumothorax when done by a interventional radiologist?
So that's a good question, because all these procedures come with a risk, especially so the pneumothorax. And to best of my understanding, pneumothorax does happen in 8 to 10% of cases, but in most of them that is subtle. So most of the times even the radiologist won't even inform you that a mild pneumothorax has happened. So the clinically significant pneumothorax in which the patient might be symptomatic or you do want to have some intervention may be just only 3 to 4%. Rest 4 to 6% would be very small pneumothoraxes which are not clinically relevant.
Yes, sir. Thank you for that. Rajat sir, have you faced any patients with severe complications secondary to lung biopsy? Rajat sir, are you there? Okay. Let us take the opinion of Dr. Priyanshu.
Yes, sir. I had one patient of actually breast cancer with lung metastasis. So we had a very, she was around 55 or so. During lung biopsy, she had a major complication because the biopsy needle actually punctured through the bronchus, and she had a lot of bleeding and had to be intubated. She somehow survived. So there are some patients, although that was we had weekly probably 15-20 biopsies going on in names, and out of the 3-year residency, I just saw one severe case. So it is the finite possibility is there, but in experience had and careful selection of the patient, I think so it can be minimized,
Yeah.
but not removed in total.
Yeah. So thank you, Priyanshu. So Dr. Kshitij, so how do you like to proceed in this case? Because this patient has underwent, CT scan, PET CT, biopsy. Now we have a 67 years old gentleman. How do you want to proceed? Dr. Kshitij, are you there? Dr. Kshitij Domadia.
Oh, yes. Yes.
Yeah.
Good evening, everyone.
Good evening. Hi.
So has a MRI brain been done?
No. That is one of the next question. Like, do you want
Okay.
to proceed? What are the other imaging tests along with the PET CT you want to do?
So yes, in early stages, before proceeding to any operative procedure, I would definitely like to screen for brain. I would like to see. I would like to definitely see brain status by MRI.
Okay.
And obviously, the mediastinal evaluation has to be done.
Yes.
Mediastinal evaluation along with an MRI.
Okay. So if you want to do mediastinal evaluation, what are the procedures? And particularly in this case with a lesion that is distinctly separate from the mediastinum, looking like a 3 to 2 centimeter lesion, let's say, clinic on a CT scan. So what is the procedure you would like to do in your setup for mediastinal evaluation?
So if I'm getting a central mass which is infiltrating the mediastinum, I will consider it to be as mediastinal involvement which is positive. So if I'm getting a peripheral lesion which is about 1-2 centimeters, and if the mediastinum is normal, then it is fine. But in the rest of the cases, I need to see the mediastinum.
Yeah, all right. So just like Dr. Praveen has clearly pointed out, so we can directly go for surgery and we can do mediastinal evaluation during surgery also. And doing the preoperative mediastinal evaluation is one of the options. So NCCN rightly exactly points out the same, that we need to do whenever we are planning for surgery particularly, we need to do pulmonary function tests, which are, there are several types of pulmonary function tests evaluated by surgeons to see the fitness of the patient post lobectomy, and bronchoscopy during surgery, mediastinal lymph node evaluation or prior to that, and FDG PET CT definitely to rule out any metastasis before going for a definite surgery. And one of the things that is mentioned is beyond stage 1B, because it is stage 1A where there is no necessity for the brain scan as per NCCN, and beyond stage 1B all patients should be done MRI of the brain.
So if it is a very early stage disease, something like 1A, usually NCCN doesn't recommend doing a MRI brain, but practically speaking, we are doing MRI brain for all of our patients. Even if you see this Adura trial, in which the early stage cancer patients, they were taken, even in stage 1A, 1B, all the patients, they had done MRI brain. So practically speaking, we are doing we are evaluating brain for all of our patients.
Yes, sir, that makes sense actually, because although 1A, the patients to pick up in stage 1A is relatively rare, and beyond 1B also, many of the institutions routinely do not do the brain scan, but it is definitely good to do a scan when you are definitely going for a costly treatments like surgery or even CTRT. The reason being, although my experience is very small, I have seen one patient who is quite well educated and who is wife of some a prominent person from a pharma industry, and she is determined to be stage 2. She is determined to go undergo CTRT, and while undergoing CTRT, she had a headache, and MRI brain was CT was done, which is normal. MRI was done. There was a cerebellar lesion, and she is later retrospectively evaluated for the EGFR mutation, and that is a hell of task to explain to them that it may be misdone planning CT also, or even normal CT cerebellar lesions may not be seen, all these things. So definitely it makes sense to do MRI brain.
No, but Venkat, why in this subset MRI brain was omitted was because
Yes.
in those peripheral lesion with less than 2 centimeter in size, so the N1 lymph nodal involvement is to the tune of less than 10%,
Yes, sir.
and the brain involvement is less than 1 to 2%. So that is why, to reduce the cost of the therapy and to reduce the other logistic issues, so MRI brain was omitted in this particular subset.
Yes, sir.
All those
I,
patients
I,
were
I
either
think
central tumor or more than 2 centimeter tumor. So those are those tumor where the N1 nodal involvement, means the hilar nodal involvement is increased. So they increase. So those are those candidates where the chances of brain metastasis or some distant metastasis increases significantly as compared to peripheral lesion. I think what we are doing is we are getting MRI brain done in all the patients, because most of the times these patients they land up to us in a OPD of surgeon, and they decide whether to go ahead with MRI brain or not. So at later time we usually do not get it done.
Yes, sir. Yes, sir. Point very well taken, sir. So obviously, the whether to do a particular metastatic evaluation or not is definitely decided by the incidence of metastasis seen in particular stage. That's why in a very early breast cancer, where we'll do very little evaluation, including only CBC or sometimes, and ranging from local advanced breast cancer, where we need to do bone scan or even PET CT. So it is depending upon the number of what is the chance of incidence of metastasis pertaining to that stage. So point very well taken, sir. So this patient who underwent surgery. So this is the histopathology report, and it is showing a 2.9 into 2.5 into 2 centimeters single tumor, which is invasive adenocarcinoma by histology, which is SNR predominant, and it has a micropapillary component of 25 to 30%. It is moderately differentiated. So the final pathological stage is PT2 PN1. So Dr. Satyanarayan, whenever you see you encounter a patient with such a report, and the patient is coming with a histopathology report after surgery, what are the points you wanting to see within the report, so that to decide upon the adjuvant therapy?
Sir, regarding adjuvant therapy, radiation therapy, I will see the margin status of the resected section and the involvement of the node. So if it is margin positive and N2 stage of node is involved, so in that cases, I will consider, especially for margin positive, I will consider, sir, adjuvant radiation.
Yeah. So as of now, I think the main indication of post-operative radiotherapy is margin positive. Manish sir, do you have any more comments on this?
I think I agree with Satyanarayan, and we would like to see all these parameters, nodal involvement, then dealing with 1A disease, what is the size of the tumor, whether there are some high risk features present or not. Otherwise, yes.
Yeah, thank you. So Dr. Pallavi, Dr. Satyanarayan point about adjuvant radiotherapy. Is there any other type of adjuvant therapy you want to give in this patient, considering the factors of size, differentiation, and other things which you see in the report? Dr. Arpit Jain?
Yes, sir.
Yeah.
It seems to be a stage 2B disease. So we'll go for the adjuvant chemotherapy for 4 cycles, followed by we'll do the EGFR testing, and accordingly we will proceed.
So why do you want to do EGFR test in this report? Which factor provocates you to do the EGFR report?
So just in line with the ADORA trial of inclusion criteria of the ADORA trial,
Yeah.
where they enrolled the 1B to 3A disease. So
Yeah,
it
because
is
of adenocarcinoma, basically. Do you do
Yes,
in other types of histologies also, EGFR post-surgery?
So we can do it in the very young non-smokers squamous cell carcinoma patients also.
Yeah.
Or in the adenosquamous
that is the principle mainly applicable for metastatic carcinoma as of now. Yes, as you rightly pointed out, adenocarcinoma, and we need to do EGFR mutation also. And what is the chemotherapy you want to give in this patient?
So 4 cycles of pemetrexed plus cisplatin-based chemotherapy.
Yeah.
So
all
we
right.
can also discuss for the role of vinorelbine plus cisplatin, but we'll prefer for the pemetrexed plus cisplatin-based
Yeah.
chemotherapy.
So, Dr. Priyanshu, we know that because of availability of osimertinib, we are doing EGFR. Do you want to do Alcon PDL1 also in early lung cancer? Are you practicing it, or do you want to do in the future?
So recently, atezolizumab has been approved for adjuvant in adjuvant setting in PDL1 positive. So I would like to do that, but and in future probably we'll be having adjuvant ALK, probably lorlatinib or such drugs also. So currently, I'm doing EGFR and PDL1 only.
Okay. Dr. Kshitij, out of all the 100 patients, how many patients do you see undergo surgery, and what are the factors that may prevent the patient to undergo surgery even when they are fit due to the clinical stage? What are the other factors that prevent them from undergoing surgery?
Hello.
Yeah,
Sir, your
Kshitij.
voice was getting interrupted. Sorry, sir, I didn't get the entire
Yeah,
question.
yeah. So
Yes.
out of 100 patients you see in a early lung cancer, why
Okay.
some of the patients defer the surgery, are unable to undergo surgery? What are the possible reasons in your practice?
So mainly it is the stage.
Yeah, early stage. Let's say they are the stage is the stage is such that they are fit for they need surgery. But
Okay.
if at all they are not undergoing surgery, what are the main reasons?
Their performance status,
Yeah.
their age, their comorbids, their pulmonary function test, all these things should be looked upon.
Okay. Medical inoperability. All right.
Yes, medical inoperability. Yes, sir. Yes, sir.
Yeah. I will take this question. I would like to ask Dr. Praveen sir. What is the role of neoadjuvant therapy in early NSCLC as far as EGFR positivity is concerned? So, are you hopeful that because of the excellent results in the adjuvant setting, it will pave its way into the neoadjuvant therapy? Because normally the drug cycle from the metastatic to the adjuvant to the neoadjuvant, that is the normal way of any drug. Now we have osimertinib from the metastatic to the adjuvant setting. Do you think that it will pave its way into the early neoadjuvant setting also, sir?
So I totally agree. So there is a trial by the name Laura which is going on, and so it's in I think Laura, no, Neo Adora,
Neoadjuvant.
Neo Adora,
Yeah.
something like that.
Yes, sir.
So there is a trial going on, but there is one particular concern about this, because these drugs most of the times they are static drugs. So if you are using it in a early stage lung disease, and if there is good resist response, so while doing a surgery or while giving radiotherapy to that particular lesion, so what will be the volume size of radiotherapy? So these concerns are still there until the time the result of this particular trial is available. So it will be very difficult to comment on the role of EGFR targeted or some other targeted therapy in the neoadjuvant setting. But however, the role of chemotherapy is definitely there in case uh, the lesion is so in case there is N2 nodal involvement, and where the surgeon feels that yes, post neoadjuvant chemotherapy there will be a role of surgery.
Yes, sir. So it is very interesting trial, like you said, sir, and there are definitely concerns because we may be using up the very potential surgery or potential drug, that to static drug in the neoadjuvant setting, and we may end up with nothing unless we have more and more discoveries in this setting. So
And
coming to this, yes,
Venkat, there is also one more concern. Let's see the resectability status of a mass in lung cancer. So it is done in the upfront setting. So once a mass is unresectable, that is going to be unresectable throughout.
yes, sir.
So if a mass is not resectable, then there is no point of giving neoadjuvant chemotherapy, neoadjuvant this targeted therapy. And there will be 20 to 25% of the patient who will be inherently resistant to this particular targeted therapy, and you might lose the window of opportunity of giving a definitive therapy, may it be CTRT, may it be surgery. in these particular patients.
Yes, sir. So that is really important point, because the extent of disease, what we see radiologically in CT scan or PET CT scan, is not only the extent of disease, it's not the real extent of disease. There are several factors. There are circulating tumor cells and several latent disease. That's why when we discuss about early stage lung cancer, this is the reason why I am showing this slide, because when we say start with stage 1B, where we say that we are starting with a curative intent, but when we see how many patients are alive by year 5, there nearly 33% of patients we are losing for stage 1B lung cancer, even with the adjuvant chemotherapy, which means only 2/3 of patients are alive by year 5, even in such a early stage, which Dr. Praveen has clearly pointed out. When we are not selecting the patients clearly, as once the patient is unresectable, he is unresectable for throughout. In the same way, when you see stage 2, nearly half of the patients we are losing by 5 years, and stage 3, 61 patients. In the same way, in this slide, I want to focus on this blue shade, where 3% of patients, they are being benefited with adjuvant chemotherapy 4 cycles in stage 1B, and as you move on from stage 1B to 2 and 3, the number of patients getting benefit from chemotherapy drastically increases. Nearly 1 in every 10 patients is being saved due to chemotherapy. In the same way, as Dr. Manish has clearly shown the benefit of adjuvant osimertinib in those patients who are receiving adjuvant chemotherapy, also in those patients who are not receiving adjuvant chemotherapy also, both are being equally benefited by osimertinib. And there is no doubt, when we see this curves, where we hardly see in the history of medical oncology, the DFS benefit getting so much with osimertinib. But as we can see here, the hazard ratios 0.17 and 0.12, which means nearly 83% and 80% of patients, they are being prevented from any event of progression or death related when we are using osimertinib in such patients. However, when we see the Indian setting, we cannot undermine the effects of RADIANT as well as CTON. However, these are Chinese trials. We may need our own trials to see whether in a patients who may not be affordable for osimertinib, whether we can use these drugs at least to prevent some more deaths, to prevent some more morbidity in terms of relapse. But as of now, we have the golden molecule called osimertinib to use it, and whenever feasible and whenever the finances allow, we should use osimertinib, particularly to prevent the CNS recurrences, which is the most dreaded complication. Once which happens, both the physician and patients are equally depressed because of the poor prognosis of CNS metastasis. So at the end of this session, if we ask, is ADARA practice changing, or do we need to wait for OS benefit? If we really wait for OS benefit, we may really not see any benefit in this trial in terms of OS, because the patient, as Dr. Manish rightly pointed out, the trial has been allowed for the crossover, and so we cannot really see whether real OS benefit will be seen at the end. But as of now, osimertinib is recommended in all the adjuvant settings from stage 1B to stage 3B, where there is incremental benefit in terms of decreased relapse in CNS and probably OS benefit. Thank you and good night.
Thank you, Venkat.
Thank you.
Thank you, Manish.